Welcome to our latest hospital data launch. Last year around this time, we had a big event on coronary stent overuse, and this year we're focusing on unnecessary back surgery. I'm Vikas, Saini, president of the Lown Institute, and I'm really glad to have you all here for this important conversation. So reducing harm from low-value care is at the heart of what we do at the Lown Institute. Our late founder, Dr. Bernard Lown, built his career on high-touch, low-intervention approaches in the exam room. And he used to say we should do as much as possible for the patient and as little as possible to the patient. So that's why we've included measures of avoiding overuse in the Lown Hospital's Index of Social Responsibility. The index ranks over 3,500 hospitals on 54 different metrics across equity, value, and outcomes. So we release these rankings and grades every year for these hospitals. One of our key measures is how well hospitals avoid 12 commonly overused services. These include spinal fusion, laminectomy, and vertebroplasty, which are often overused in patients with low back pain. Low back pain is incredibly common and debilitating. It is the single leading cause of disability worldwide. Although I might say that might have been before COVID. Most people experience it in at least once in their lives. And we're interested in how common this condition is in our audience today. So if you've ever experienced low back pain, here's a quick poll. Why don't you just fill that out for us? Some low back pain is caused by structural abnormalities, trauma, or cancers. And for these, surgeries can be absolutely helpful. But most low back pain doesn't have a known cause. It's called nonspecific low back pain. And there's little evidence showing that surgeries of these types can help those. That's why some clinical guidelines recommend against it, and why researchers have previously cited these surgeries as indicators of overuse. So what did the poll say? Currently, yikes, almost a third of people. So it just proves it is a very common thing. And only about 15% have never, so you're lucky. You must be doing something right. Keep it up. It's important that hospitals and physicians take care to avoid unnecessary back surgeries because the potential for harm is significant. That's true for any major surgeries. Complications include infection, blood clots, stroke, heart and lung problems, and in the case of spinal surgery, paralysis, or even rarely, death. For spinal fusion, the rate of major complications can range from 10 to 24%. The incidence of failed back surgery syndrome, in which the vertebrae don't correctly fuse together after surgery, can range anywhere from 10% to 40%. So today we're really happy to have some guests with us. So how prevalent are these surgeries? What drives them, and how do we reduce harms from back surgery overuse? Claire Brockbank is with us. She's the Director of Policy and Strategy for the 32BJ Health Fund, which insures over 200,000 people and is soon starting a Center of Excellence for Spinal Surgery. In her work, Claire focuses on efforts to drive down hospital prices through public policy, operational innovation, and direct negotiations with hospitals. She holds a master's degree in health policy and management from Harvard. Also with us today, we're pleased to have Dr. Sohail Mirza. He's a nationally known orthopedic surgeon specializing in complex spinal diseases, cancers, and injuries with a special interest in spinal biomechanics and surgery. He's also published on conflicts of interest in his field. He's currently a professor at Dartmouth. He received his MD from the University of Colorado and MPH from the University of Washington. So welcome to you both. So Claire, just to kick us off, can you tell us a little bit more about 32BJ Health Fund and who your members are?
Yes, absolutely. Thank you, Vikas, for having me. So as you mentioned, we have about 200,000 members. These are, and they're in 13 different states along the Eastern Seaboard, but really the big concentration is New York, New Jersey, Connecticut area. These are residential and commercial real estate workers, so the doorman, the superintendent, the window washers, some airport security, some teacher, some school maintenance staff. So really frontline blue collar workers for the most part. And so their musculoskeletal issues are important for us because they're a fairly critical part of their work. We take our responsibility of managing their access to healthcare really seriously and currently provide $0 premium coverage, which is pretty rare these days. But we also work very closely with our members to help them understand that doesn't come for free. So we've eliminated super expensive hospitals with their blessing, their explicit blessing. They now understand that unnecessary and overpriced services, every dollar of that is a dollar out of their paycheck. So that's how we work in partnership to keep that low premium care. So it's a great collaborative environment.
That sounds amazing. And just to clarify, you said $0. You mean no out-of-pocket costs?
No, it's no premium. It's almost no out-of-pocket if you go to our designated hospitals. So for the Center of Excellence, which we'll talk about more, that is all told $100 inpatient copay for your entire spine, knee, whatever. It's more if you go to what we consider our second tier hospitals, and we base that on quality and price, both. So again, we have a Union Health Center. If you go there, it's free care. Primary care is free if you go to our patient-centered medical home. So we try to find a way to make care free, but only if the member engages.
Got it. Excellent. So, Sohail, you're a professor of engineering at Dartmouth, I noticed. Not a lot of physicians can say that. So how do orthopedics and engineering intersect?
Orthopedics is, in some words, fancy carpentry, so there's a lot of overlap. I actually was a physics major, and I still sometimes wonder if that would have been a better path. But for various reasons, I went into medicine, but then found a home in orthopedics. So the Thayer School of Engineering is very proud to focus on surgical innovation. So after 20 years of writing about too much back surgery, I'm now switching sides to developing technology to make it easier or safer.
Yeah, interesting. I just saw a paper last night showing some new surgical robots that literally learn by watching videos of surgeons. So you may be training your replacements like many of us have been doing for a while.
Yeah, no, the robots are very, very good, very sophisticated. But in the end, the companies are very smart. They still make the surgeon push the final button for liability.
Yeah, for liability reasons, absolutely. Well, look, let's get into it. Let's dive into some of the data on back surgery overuse. So at Lown, we found that over a 3-year period, hospitals performed more than 200,000 back surgeries that met criteria for overuse. And that cost Medicare roughly $2 billion. So that's 1 every 8 minutes, but that's if the OR is going 24 hours a day. If you're only going 12 hours a day, that's 1 every 4 minutes. So that's quite something. Spinal fusions and laminectomies are performed to treat back pain, either by fusing parts of the vertebrae together or removing parts. We counted them as overuse after excluding several conditions, including trauma, radiculopathies, and scoliosis or structural abnormalities, where these surgeries would absolutely be indicated. We found the average rate of overuse was 14%. But as you can see in the slide, the variation among hospitals was pretty striking, with some doing only 1% and others doing 40% or more. Even among hospitals on the U.S. News Honor Roll, there's a lot of variation. For example, the Hospital of the University of Pennsylvania had a rate of 33% compared to about 2% at UC San Diego. So this is spinal fusion and laminectomy. Sohail, our results are showing that for some hospitals, almost every 3rd spinal fusion is unlikely to benefit patients. Do you think we might be overcounting or exaggerating, or does this seem plausible to you?
plausible, I think, because the indications are so broad, and you've kind of excluded the non-controversial indications, which are fractures, scoliosis in adolescence, cancer-related surgery. Those are really uncontested indications, but back pain is so common, and the literature hasn't been really able to define the proper indications. And most surgeons feel like they can pick their patients better than their colleagues, so their results are better than whatever might be published or pointed to. And you'll find some surgeons really focused on it because they feel like in their hands the results are much better. So I think it's very plausible.
Is there any, I think I know the answer, is there any standardized or institutionalized way of reviewing these matters? Peer reviewing these matters? Or is it essentially once you got a license to practice, you practice medicine and that's it?
Well, the answer is yes, there are standardized reviews. Every insurance company almost always requires pre-authorization. But really, if you're committed to getting something authorized, you can find the proper language to get it approved. So a lot of times unindicated surgery, in my opinion, surgery that may not be scientifically proven to necessarily benefit, can pass under the radar. It can be done very well, very efficiently in relatively healthy patients and have really no complications, which are really the outcomes being used, even at the Lown index, are readmissions, reoperations, mortality, infections. So if you pick healthy patients who are not going to have complications, you can kind of go under the radar for any scrutiny for something that may not be supported by the literature at all.
Yeah, we definitely, at the Brigham, the surgeons would say, oh God, another Lown patient, they're so sick. And we used to respond by saying, sure, you can operate on healthy people, you'll get great results. All right, well, let's turn to vertebroplasty because there we see a similar story. The procedure is often used to treat spinal fractures by injecting medical grade cement into the vertebra. We count this as overuse when it's used in patients with osteoporosis and only osteoporosis, but we exclude it when those patients have bone cancer, myeloma, or hemangioma, where we'd consider it appropriate. Now, it's important for the audience to know that in 2009, there were 2 separate sham-controlled trials that came out showing no benefit to vertebroplasty for patients with osteoporosis. In the next few years, the number of vertebroplasties in the Medicare population dropped dramatically, dropped by 60%. So I think there's a good news story there. Doctors actually were listening to the evidence, but obviously not all of them. And so, in fact, in our data, we see several hospitals that got the memo and had lots of opportunities to be doing those and did 0. On the other hand, other hospitals had overuse rates over 40%, doing hundreds of these procedures. Here's another example from US News Hospital Comparisons. At the Cleveland Clinic, less than 1% of patient visits for osteoporotic fractures resulted in a vertebroplasty. At Mayo Clinic Phoenix, the overuse rate was 20%. So I want to turn to our panel and just ask in general, what do you think of these results? Claire, I know you've been focused mainly on variation in prices at the fund, and that of course has a huge impact on affordability for your members and what benefits you can cover, as well as sustainability of all this over the years. But how might clinical variation of the kind we're showing you, how might that be meaningful to you as a payer?
So some of that was what caused us to say we needed a different focus for our spine surgery. We're not clinicians, and so I'm looking for support from partners that do have a strong clinical source of expertise. But this report highlights that even within that, obviously we focus on at the provider level, the provider decision maker level, as opposed to the hospital. So that's a little bit apples to oranges. But we do in many of our programs, but not spine at this point, although I'm interested in the discussion today. We do look at outcomes and use that to pick hospitals for some of our specialized programs. We have a maternity program where members can have a baby for $40, so all told, including the car seat. But the hospitals that participate in that program, we track and we spend a lot of time educating them on episiotomy rates and C-section rates, and we've seen those go down, right, with that level of intervention. So we definitely factor in, because in our eyes, quality and cost go hand in hand, and people don't always think that in healthcare, right? But higher quality should be lower cost if you're doing the kind of volume and with the sort of efficiency and focus. I did have one question for Dr. Mirza, and actually also for you, because do we see, once you've had one unnecessary spinal surgery, are you more likely to have a second one? Do we see higher repeat surgery volumes? Because of course, for an employer, that's a red flag also, right? To pay attention to our first surgical candidates. So I don't know if we know the answer to that.
That's a great question, and I'm going to, pose it to our guests, and I'll rephrase it a little to say, are there higher rates of surgical failure when the surgery is inappropriate? My guess is no, but what do you think, Sohail?
I think the answer is unequivocally yes. It's one of the old adage, if it's not broken and you try to fix it, you will cause issue. So one of my teachers at University of Washington used to call this iatrogenesis imperfecta, because if you have iatrogenic induced injury, you're going to keep doing more and more. And I think the literature is very clear that once you have any kind of back surgery, you're on a path to have more and more back surgeries. And one of the data sets we looked at in Seattle was the number of back surgeries you'd had in the previous 10 years was kind of predictive of how many more you were going to get. So it's very associated. And I think if the problem wasn't properly diagnosed to begin with, and you did a treatment that creates scar tissue for sure and creates stiffness for sure, you're going to compound the problem.
Well said, and I've seen that a lot in my world as well, so makes a ton of sense.
I think
So,
the other thing, because because it's important is that we make sure that we fund our earlier interventions more robustly. So we have a very generous physical therapy program, so that there's not a barrier, right, to trying the less intense intervention.
Yeah.
Right. If it only costs you $100 to have your spine, but it costs you $100 for each PT visit, and you make $60,000 a year, we don't want there to be a weird economic incentive.
Yeah. Well, the economics in healthcare, that'll take another year of seminars to cover. Anyway, let's go to another poll, because I'm just curious what our audience thinks about this. What are the drivers of this type of low-value back surgery? Lack of monitoring or regulation of appropriateness, a culture of more is better, fee-for-service, always everybody's favorite bugaboo, patient expectations about procedures, payments from device companies, or something else. You can put it in the chat. I'm going to turn to one question from the audience, which is, does Medicare still cover vertebroplasty for osteoporosis? Maybe the drop in some hospitals was that it wasn't covered. I'm going to guess that ain't so, because what we actually saw were claims that we're reporting today in our numbers, and those claims were almost certainly paid for, because that's how we got some of our estimates for the dollar values. But Sohail, you might have a view on this.
Can you explain a little bit more what you're thinking, Vikas?
Well, the questioner in the audience is asking, does Medicare still cover vertebroplasty for osteoporotic fractures?
Yes, it does. And, often the indications are failure of conservative treatment, but in many hospitals that ends up being a diagnosis of admission, fracture at admission. But if you talk to patients, and I was trained in kyphoplasty when it first came out, and I still do occasionally, maybe 1 or 2 a year when non-surgical treatment, when conservative treatment fails and patients can't mobilize. But usually if you get their pain under control in the first few days, or if they need a brace, get their pain under control, they're often very content. And by 3 or 4 weeks, they're really functioning at a pretty good level. The trial from University of Washington and Australia, many of those studies have been criticized for maybe waiting too long or not waiting long enough or not having proper criteria for inclusion. So many times the surgeons or the procedure, often now I think it's mostly done by radiologists actually, more so than surgeons, find a reason to exclude that. And many times I see the hospitalist and the primary care physician actually pushing for it because they see it as a problem that can be fixed, not understanding that, putting cement in is not risk-free and it can lead to more fractures at the adjacent levels. And the data are very questionable in terms of what degree of pain relief and how long. But the simple answer to the question is it is still covered, particularly kyphoplasty, because the randomized trials looked at the technique using a needle rather than a balloon and a trocar. So often that's used as a justification that, well, kyphoplasty is much better, vertebroplasty may not work. But the procedure codes for Medicare are the same. Well, actually, they are different, but they're still covered.
Got it. Thanks. Yeah, I'm just, as a rhetorical question, I'd ask, can you imagine if Medicare declared they're going to stop covering a bunch of these low value procedures tomorrow? What would be the impact?
So Vikas, I think I want to share a little story. When I started at University of Washington, we wrote a paper or something about maybe too much back surgery. And I was a assistant professor, very eager to kind of get papers out. And this is back in the late 90s, maybe 97, 98, something. And Medicare actually had a meeting to discuss coverage for fusion. And they invited me for some reason. I don't know how, one of my papers or something. And I kind of walked into it naively. But on the counter side, there were presidents of all major spine and orthopedic and neuro associations, and maybe 30 or 40 very high power people ready to present their data. And here I was, assistant professor, not having a clue what I was up against. So Medicare has kind of raised the question, but I think it didn't go anywhere. The coverage decision was not really a question.
I would refer people to the first line of a book called The Social Transformation of American Medicine. The dream of reason did not take power into account. Let's move on. Before we get to the poll results, I want to remind our audience about an exciting opportunity to celebrate the next generation of clinician leaders. Many people, I think maybe even a majority of the country now, would say the American healthcare system ain't working well. It's broken. I've heard people, congressmen, tell me, it's going to have to collapse before anybody really gets around to doing something about it. But we want to celebrate people trying to do something about it. We want to celebrate young clinicians who are doing what they can outside their lane to try to help improve things. So that's why we created the Bernard Lown Award for Social Responsibility. It honors young clinicians out there who are using their voice as a professional to speak out for social justice and reform. So if you know of a clinician under 45 working in the US who stands out for their bold leadership in healthcare reform, environmental justice, equity, or any other humanitarian effort, you can nominate them for the Bernard Lown Award, which comes with a $25,000 prize. Nominations close at the end of January, so skip the holiday rush and submit your nomination now. Okay, so what did the poll show? What do people think here? Aha, the plurality fee for service. Well, there's a lot to say for that, I'd say, but culture of more is better is pretty important. Patient expectations. That's an interesting one. We don't have time today, but I'll refer you to a quote from Charles Deming, the father of quality improvement and the Toyota method, who said, customer expectations? I don't know any customer expectations that haven't been planted there by you, the guy who's selling. Okay, now we're going to have another look at a deeper part of the data. So we mapped physician NPI numbers to Medicare claims to find variation on the individual doctor level. Here are spinal fusion numbers for doctors at Mount Nittany Hospital, which by our measure was one of the highest overuse hospital rates in the US. And in this case, there's clearly one surgeon in particular that's in the lead who's doing the vast majority of these surgeries. And this can happen with vertebroplasty as well. At Washington Regional Medical Center, which has one of the highest rates in the US by our measure, we found one doctor performing 70% of the hospital's vertebroplasties. So Claire, I'm guessing that data on this kind of doctor level clinical variation is not generally available to you as a payer. Is that right? And would it be something you'd act on if you could?
Yeah, I mean, we probably get more data than most payers out there, but it doesn't tend to have the kind of diagnosis information that would allow you to identify overuse, right? It's claims payment information. So I do think this is fascinating. And again, it's one of the reasons we picked our COE, because it looked at the doctor level, but we struggled with what some of the appropriate clinical quality measures are. And I think what this data points out that's really interesting, and it kind of flips it on its head, is we were looking at plus quality measures, and maybe we should be looking at the negative quality measures. I mean, you know, it's A and B side, but I think this is great and worthy of speaking with to the folks who do the second medical opinions and who provide the kind of clinical input that we don't, to say, let's start measuring our outcome against some of this information. But getting the data is always hard. You probably had to do medical claims reviews. Actually, how do you get this data?
Yeah, well, this data is, we're using Medicare claims. We have access to 100% of the claims, so it's a pretty comprehensive look. And yeah, I mean, a lot of people have approached us at Lown, you know, whether we could sort of provide some of this information, because I think it's clearly needed. And there is a gap, there's a hole in kind of the ecosystem for looking at this sort of thing.
Yeah, because so you get the claim, but you also have the diagnosis of osteoporosis.
Yeah,
And that's the key, you know, right?
Yeah. Indeed. Well, you know, the poll that we just shared had a couple of measures, but we looked at one factor that, you know, could be a driver of overuse rates. And so we had an opportunity to look into conflicts of interest and potential conflicts of interest. So we used data from a startup company called Conflixus, and they linked up our results with the open payments database that the government publishes. And they found that doctors with back surgery overuse, the list that we gave them, received a total of $64 million in industry payments for consulting, speaking fees, meals, and travel over the 3 years that we reported this. And consulting and speaking fees were some of the largest categories of payments to these doctors. And you know, it's a large group. Here are some of the companies with the highest total of payments for doctors that were performing the unnecessary procedures that we report on. And I should point out that doctors who weren't performing unnecessary procedures, we didn't include those here, but presumably they may also be getting payments. Sohail, what do you see in terms of industry payments in orthopedics? Is this something you're aware of? Are you surprised by our numbers or not?
I'm not surprised. We do see this a lot. And, you know, it's it's a problem that goes both ways. Certainly salespeople and industry representatives are looking to recruit surgeons into their product line. And they start pretty early. They'll start, courting residents and fellows in particular, and, taking them for trips and tours of the factory or various other things to basically get them to start using. But it also goes from the physicians. I've seen, I've been in a management role also in a department, and we used to have people disclose payment arrangements and other things. And many times physicians and residents will ask for consulting payments. And really, it's not really consulting in the sense for any defined work product or scope of work. It's really just having the salesperson in the room and, giving them some feedback if needed, which really is very nominal. It's mostly just payment for using their products, I think, in a simplest way. And in my mind, the 64 million compared to the $20 billion a year spinal fusion industry in the US is a small fraction. The device screws and the screws and rods we use, I would bet the average cost for a simple one-level fusion is about $10,000 to $20,000. And some of these deformity cases where multiple screws and rods are put in, the implant costs are huge. And biologics like bone morphogenetic protein or certain types of bone graft substitutes are very, very expensive and rapidly growing. And there's very little science to show one is better than the other. I don't know if any study that shows one company's product is better than another type of pedicle screw, for example. There are over 300 types of fusion cages, these little blocks of usually titanium or some kind of a polymer that the manufacturing cost may be a few dollars, $10 to $20, but the sale price is $3,000 to $5,000. So there's a huge incentive for industry to have advocates, particularly key opinion leaders, you could call them, people who train a lot of fellows, people who have influence in societies to really start talking about their products. So I can understand their motivation to pay speaker fees, sometimes conference fees, research meeting fees, but the agenda always is to sell their product.
Yeah. Well, if I'm running the company, I look at these numbers and think that's a pretty good return on investment is my guess.
Mm-hmm.
And nowadays, key opinion leaders, I guess, would be called influencers. And, we'll see if your TikTok followers will determine how much you get paid by industry. There was a question from the audience about whether inappropriate cases have higher complication rates. I think we've sort of already addressed it, because the answer may be yes, but if you're operating on a lot of healthy people, in many cases, the initial complication rate may be low. But I maintain at the end of the day that at the heart of the matter is if you didn't need the surgery, but you're getting it, any complication is, infinitely excessive. So let's go on. I want to talk a little bit about solutions. And so let's kick this off by talking a little bit about the Center for Excellence model, Claire, that you and 32BJ are adopting. You have some slides to share with us, so why don't you walk us through them?
Thanks, I'm happy to. So we can go to the next one. But the gist is that we look at how do we make sure our members are going to high quality providers and that we're using the leverage of our volume to get the most affordable price at the best places. So we added spine because it's one of our high volume procedures, and because of the literature that says there's so many unnecessary procedures, we don't necessarily know how to find them. So we looked for a program that would do pre-surgery consultation, never by the surgeon who will do the surgery, right? So it's by a panel of experts, as well as one that really looked at the qualifications of individual surgeons. So we have one hospital that only some of their surgeons can operate, and we wanted to make sure we were using outpatient facilities, et cetera. So this was really our effort to make sure that our members who have spine surgery have it because they need it and that they have the highest odds of a good recovery, all of which are win-wins for an entity that's paying a healthcare bill. So we go to the next slide. So we have had COEs, but not for spine, for the last several years. And when we decided to go with spine, we decided to also do a broader look at who we were working with. And again, our COE is mandatory for spine. So if you need a spine procedure, you have to do it at one of our COE places, unless you don't live proximately to it. There's some medical exceptions. Likewise for total joint replacement and bariatric. It's easier to educate our members that this is the way we do it. So I'm going to go on and give you, we're just launching it in 25, so I don't have a lot of results and data to show you. We have some quality metrics, but I do want to talk about some of the ones this report has surfaced. But if we go to the next slide, this is the one that I think is super important. This may be a backdoor, and Dr. Mirza might have some thoughts on this, but we wanted to identify of our members in New York City. We sort of stuck with a focused area. We had 172 different spine surgeons who operated on our members last year. And we provided that information to Lantern, and together we ran them through their quality metrics and their credentialing, the volume of procedures they do, board certification, et cetera. And we were fairly stunned that only 32 of them met their preliminary quality criteria. These are not cost criteria. There's nothing to do with money in here. This is purely about whether they do sufficient volume, they're board certified, credentialed, et cetera. We do then look at additional metrics. Well, we don't, Lantern does, like malpractice reviews. There's some on-site interviewing. They do look at some trend data and facility evaluations. So for us, this slide is really the heart of our first shot at really tackling spine surgeries. We coupled it with unlimited virtual PT, again, so that they can recommend that you do PT before your surgery, and it's not going to hurt the member or cost the member. So it's unlimited virtual PT, as well as, of course, we have PT available for those who prefer to do it in person. But I think these numbers are really, really stark. That means we had 140 surgeons who don't meet some minimum volume requirements operating on our members. That scares me. So I think we have one more slide.
Yep.
So one of the questions is, how do you, for those so first we try to find the right surgeons, right? Or Lantern tries to find the right surgeons in the first place. But then anyone with a spine surgery is going to have a consultation with an independent Lantern surgeon. And they look at, again, this is not our data, but they look at about 30% of their cases not fitting into the initial funnel for surgery. And 62% of those, 2/3 of those, are really that it was a very aggressive strategy when pain management and PT, other mechanisms hadn't been considered. That's that's an important thing to always try first before you put a scalpel to someone's back. The second thing that's important, though, is that when the member's not healthy enough for surgery, it doesn't mean surgery is not the right outcome, but then we sort of bring them in and walk them through, how do we get you to how do we address your medical needs? How do we get your HbA1c under control? Whatever it is, that we will take the ones that Lantern determines are not healthy enough, and to the extent we can intervene, we will intervene to help them get to a point where it's a choice. And finally, this misdiagnosis, that's the 22%. That's Dr. Mirza saying, if it ain't broke, don't fix it, right? And deciding that it's a misdiagnosis. So those sort of give you a snapshot of what we're trying to do on the surgery piece. It's a pretty limited perspective, but we're pretty excited about it because it's very doable. We've put this program in place quite quickly, relatively speaking. We'll be getting all the data from them, so we'll be looking at this data to see how it plays out. So stay tuned.
Great, thanks. A lot to talk about here. Certainly, I've had some experience in conversations about potential centers of excellence for cardiovascular. So, you know, there are many considerations to think about. But Sohail, what do you think about this concept and the sketch that we just got from Claire? Does that seem like it's worthwhile endeavor? And what else would you add to it?
In general, I'm not sure how these programs that are intended to funnel patients in a certain direction work, and what the blowback might be from the patients, who are really risking having their body being cut on by a surgeon. And if somebody tells them to go see this person, I think there will be resistance to some patients saying, no, I don't really like that surgeon, don't trust that surgeon. Because it's a big deal for somebody to consent to have a surgery, particularly a life-changing surgery like back surgery. And I think, 2 cases a week, 100 cases a year, that's a pretty good, I guess, benchmark. But I remember a lot of the earlier cardiac programs, you probably know much better, when these things started getting reported in New York and Pennsylvania in particular, and many of the cardiothoracic surgeons who were doing fewer than 50 got blocked out. So I'm not sure just having a count necessarily is a metric for quality. Some of the surgeons that will show up in your high user or high overuse rate, Vikas, maybe surgeons who do 500-600 a year or even more. So there's probably a point at which more surgery probably means more lenient criteria, and I'm not sure what the right balance is. I think a better metric might be how many patients with a certain diagnosis like spinal stenosis that surgeon sees, and what fraction of those patients end up getting surgery by that surgeon. So some kind of ratio where it balances their clinic volume with their surgery threshold, I think would be more meaningful than a pure metric that counts the number of procedures they did.
Yeah, I mean, certainly this has been an issue with regard to surgical quality. Volume is a necessary but not sufficient condition, is I think the right way to think about it. I don't want to go to somebody who does 1 a year and hope that it goes well if he's going to operate on me. But by the same token, to the extent quality became volume, and in a lot of reports on quality from various report cards and elsewhere, that's really all it is. It kind of rewards people for operating on anybody and everybody, and that's not good. So there's no.
I think that's why the second medical opinion is important. And if we see consistently some of our accepted surgeons, our approved surgeons, have a very high rate of misdiagnosis, we'll be watching those. And those are ones that get re-reviewed because, in theory, to your point, they're churning potentially, right?
Yep.
So I think you do want to always have it with another clinician taking a look at the patient. But you're certainly right that this is not foolproof. It's a first cut, and we'll be looking at readmissions, and we'll be looking at some of the pain measures post and pre-surgery, et cetera, to try to get a feel for whether we've gotten there. Checking the malpractice, I know that's a really big club. But the misdiagnosis and tracking those to the physicians as a way to say, we're turning down a lot of your patients, and yet you're one of our COE providers.
Yeah. There's a question from the audience that is actually, I think, really profound, and it relates to the issue of trust. And the question is, how do we get the message about overuse out effectively to the general public, while at the same time rekindling trust in the public? And I will confess, this is a really complicated issue. And I don't think any of us have figured it out well. So on the one hand, right, there's some bottom line level of trust when you go to see a clinician, a physician, primary care doc, they refer you to a surgeon. You know, you assume certain things about that relationship. But as you said, Sohail, if there's a center of excellence or some third party that's sending somebody another way, at least it's going to raise questions, and you need to have a narrative and understanding for what you do about it. Now, there's growing kind of concerns and a decline in trust throughout all our institutions. I don't have to tell people on this call that. And so how we address that, I think, is going to be really tricky. One question for you, Sohail, is as a specialty or as a profession, what do you think that, you know, orthopedics could be doing more publicly to help reduce the incidence of low value care?
I think that's from the board point of view. You know, there's no board for spine surgery, and I get nervous about general orthopedists doing even simple spine cases like discectomy and laminectomy, because many times that's where the iatrogenic cascade starts, is a misdiagnosis or a technical complication. In terms of the professional societies, I think, to Claire's point, the data on joint replacement has been pretty clear in terms of volume and reoperation rates, because in primary total knees, primary total hips, the diagnosis is pretty uniform, comorbidities are accounted for, and the data has been pretty clear that surgeons who do fewer than 25 a year have higher repeat surgery rates for primary total knees, primary total hips. But more than half are done by surgeons who do fewer than 25 a year. And the society has not been able to deal with that, because more than half their memberships would not tolerate any incentive to shift those patients to surgeons who might be more specialized, like fellowship trained in joint replacement, as opposed to a general orthopedic surgeon who might do one a month of a total knee, but then do meniscus or shoulder and spine and a whole bunch of other cases the rest of the time. So I think at the simplest level, the boards could be very helpful, because you do have to get recertified, and the American Board of Orthopedic Surgery does a case review. I think if there was better scrutiny of what kinds of cases a surgeon is doing, that should be the first kind of quality metric. You know, I used to have a colleague who would interview, you know, do oral exams for board certifications, and he would tell us, you know, if somebody from rural Montana is doing 300 fusions a year, that's out of place. That by itself stands out as something that doesn't fit. So I think that could be a level. I think the professional societies, if they really wanted to focus on quality and outcomes, could help a lot. They do have registries going on, but participation is very expensive and very kind of patchy, sparse, so the data is not really very actionable. I think there is a role for both certification and professional associations, but it hasn't really fully been leveraged.
Thanks. As an aside, I'd say nothing would make me happier if the Lown Institute was put out of business, because this stuff was adopted and managed. Claire, an interesting question from the audience for you, because I think it opens up a bigger picture of health, public health, how we live, how we work. Do you take your Center of Excellence data, or do you plan to take your Center of Excellence data back to the employers to work with them to think about how might we prevent back injuries that are work related that might result in the surgery? Or is this sort of outside the realm and something that the employer has to do on their own, or work with OSHA or whatever that regulatory environment is?
So for us, we're a union environment, right? So we're a somewhat unique union environment in that the union and the employers jointly manage the funds, right? And they are fairly fiercely opposed to each other at the contract negotiation table, right? Where wages are important, et cetera. But they do they are in lockstep on the fact that healthcare costs are what's taking all the oxygen out of the room for other benefits, right? A living wage, pay, retirement, pension. So we represent about 6,000 employers all under the umbrella of the union. We don't do workers' comp because of the way labor relations laws work. So they are aware of this data because we talk about it at the trustee level. We have a very actively engaged board of trustees. But individually, this won't go back to individual employers. We could potentially, but some of these are mom and pop shops. Like they may own one building in the Bronx, right? And their workers are in the union and they look to us. So part of it is that we've built a lot of trust over the years. So it doesn't go back to the OSHA piece, but it does go back, Sohail, to your piece, which is that our members know that when we put a program in place, it will directly benefit them. When we removed New York Presbyterian from our network and we worked with the union, they voted unanimously on it. We shared with them cost and quality, et cetera. They got their biggest raise in history. The employers got a bonus. They get to reap the benefit. It's not coming to us, like our administrative costs are a couple percentage. So there is a lot of trust by the members that when we put something in place, we're only motivated by that, right? We're pretty skinny, but so that's really to the earlier comment, but we don't take it back. They really look to us to think about what to do with this information. That's not a typical response though. And in reality, employers should be looking at this because if we think musculoskeletal is high on the health side, I've done a lot of work in workers' comp and it's off the charts on the workers' comp side, off the charts. So this should be really relevant in that environment.
Yeah. Well, there's one question. We're running out of time, but I just want to try to sneak it in because it really goes to the heart of a lot of different pieces of the puzzle, which I've been thinking about for 20 years now. And that is, Sohail, you were just talking about how, if half the physicians do less than the minimum required for a quality metric, it's hard to get a quality metric adopted if it's majority vote. Half of them will vote against it. So this is a related question, which is about the workforce. Do you think we're producing more spine surgeons than we need? If we had less of a number of surgeons doing more, would we get higher quality? Do these surgeries, where they happen, would they be done more on indications? And how would that even happen?
So in the area where I do cases now, in this Fairfax area of Northern Virginia, in a 10-mile radius, there are, I think, more than 85 spine surgeons. So many times, the second a patient walks in, the surgeon in their back of their mind might be thinking their open block time, a week from Monday or whatever, and say, well, this patient could wait, but they're going to need it anyway, might as well schedule it. So I think, yes, there are probably more spine surgeons than needed for properly indicated cases. But the flip side that I have kind of a skewed, you might call it like a socialist view on it, is I think the numbers for the average amount of time an orthopedic surgeon spends with a patient before signing them for surgery, maybe like a 16-minute visit. So, I chose to practice in a very different way, not that I'm kind of claiming to be better than anyone, but in many ways, I think you need a lot more surgeons and have them do a lot less in terms of clinic volumes and surgical volumes and spend more time with each patient. But if you go with the current rates where surgeons will see 20 to 40, sometimes even more patients in a surgical day, 100 to 200 patients a week, and operate on 4 to 6, maybe 8 fusions a week, you certainly have room to kind of add more surgeons to slow that pace down. But I don't think anybody's going to tolerate lower reimbursement. So I'm not sure what the answer is. I personally think each surgery is so complex and so intensive that it should get paid well. But I also don't think you should be having to kind of run a conveyor belt of surgeries to pay for your overhead and PAs and building and staff and everything else. So I don't know the answer to that. There's no simple answer. I personally think there should be more spine surgeons, and there should be a lower pace for each surgeon.
Interesting. Well, certainly a different reimbursement model might address that. We might actually save money in aggregate by paying spine surgeons well, but independent of whether they're operating, and then figuring out other criteria. So
And
we
if you
really,
had like something like a lifetime commitment, or, you know, a 5-year commitment to the patient where you got paid once. You know, when I was in residency, one of the surgeons at the VA used to argue for that if you got only paid once but had to take care of all the subsequent complications, you would be much more thoughtful about which patients you picked if you had to
Yeah.
own the complications afterwards.
yeah. We got to wrap it up, but if you can, very briefly, Sohail, this is something we always like to talk about with low value care, which is if someone has low back pain, what kinds of questions should they ask their doctor when they go, or if they're being offered this procedure, what are the questions to ask?
I think the first thing is what everybody's been pointing to. You need more opinions. You know, these are vulnerable patients. They're looking for a quick fix. And I see so many patients who wish they had sought additional opinions before signing up for an invasive treatment. So I would say anybody with back pain, if the first thing they get offered is either an injection or an ablation or some kind of surgery, that they need to look elsewhere first before signing up for that procedure.
Thank you. All right, well, we're out of time, but before we go, I want to thank our guests. Claire Brockbank is the Director of Policy and Strategy for the 32BJ Health Fund. Dr. Sohail Mirza is an orthopedic surgeon and professor at Dartmouth University. Thank you both so much for your insights. They were really valuable. And thanks to everyone here for joining the discussion. It was very robust. I couldn't keep up in the chat. But you can see more of our data on back surgery overuse at lownhospitalsindex.org. And to get our free newsletter and learn more about events like this, you can subscribe to the Lown Weekly. And tell your friends. Have a great afternoon, everyone. We'll see you next time.
Thank you, Vikas, for inviting me. Claire,
Thank you
nice
so
to meet
much.
you.
Take care.